So we turn now to the next session, and it's Xavier is going to be the host for that.
Thank you, Peter. So the next session will be, we move to next session 4, called Understanding Clinical Outcomes for Better Management Care. And so the first talk will be given by Lynn Barrett from Cardiff, UK, exploring the psychosocial issues in patients with VEDS. So Lynn, if you could just put your presentation on.
Yep, I'll just upload it now. Okay, so hi everyone, I'm Leanne Barrett. I am an MSc or graduate MSc student from Cardiff University, and I conducted my dissertation research looking at the psychosocial impact of living with vascular Elastano syndrome. So as you all know, vascular EDS is an autosomal dominant condition and is characterised by many things, including excessive bruising, tissue fragility, and an increased risk of sudden death. And just in the beginning of my entire research project, it became very evident that there was minimal psychosocial research into vascular EDS, and any published literature that there was sort of combined vascular EDS patients with other patient groups. But there was no patients from the UK that had their views voiced. So when I conducted my literature review, as you can see on this slide, a lot of the studies were sort of combined. So the vascular EDS studies were usually reported with Marfan syndrome patients and Loeys-Dietz patients. The sudden death disorders, I looked at long QT syndrome and hypertrophic cardiomyopathy. I also looked at classical and hypermobile EDS studies and Loeys-Dietz syndrome and Marfan syndrome. And throughout the literature review, there were some common themes that sort of came up from all of those groups in regard to the psychosocial issues those patients faced. And they included things like grief and loss, physical functioning, frustration with healthcare professionals, and issues with family and concerns around future children. So using that, I sort of set my study aims and objectives to kind of look at those areas and explore that with vascular EDS patients. So my materials and methods, I was lucky to work with Anomalies Challenge. It's an amazing charity here in the UK, and they have a large database of vascular EDS patients. So a recruitment advert went out to them, and then individuals that wanted to get involved contacted me directly, and we had an initial phone call just to sort of discuss the study in a little bit more detail, because this was the first research project that they'd done in the charity. So it gave them an opportunity to ask any questions before we arranged their interview. I chose to do semi-structured telephone interviews just because the demographic of patients was all across the UK and I'm based in London. So it was an easy way to get more participants on board. And I also offered all of the participants a debrief phone call 1 month after their interview to give them the chance to sort of reflect on their experience. It became very apparent that for a lot of them, they hadn't necessarily spoken about how the condition had affected them psychosocially. And that was something that they really appreciated. I then analysed my data using thematic analysis, and I will show you my results. So in total, 34 consent forms were returned, and of that 34, 21 participants were interviewed in total, so that was a good number. I had 18 women and 3 men, and they aged between 19 and 61 years old, so I had quite a large age range. As you can see, there were 6 key themes that were identified. There was, within those themes, there's sub-themes, and those sub-themes have sub-themes because there was a large amount of rich data that came from this study, which is obviously amazing. And I'm going to talk to you in a little bit more detail about each of the themes over the next few slides. So physical limitations to daily life was probably the biggest thing that came across with participants. The idea that their physical health limited or directly or indirectly limited their ability to do certain things came across massively. So from fatigue and pain, things like the bruising and the skin tearing made life very difficult for them to carry out daily tasks. Everyone commented on this idea that they were limited in what they could do each day. So they had to sort of almost plan their time and what they would do and what things would use different energy, because they were always so tired. And that obviously had an impact on their engagement in social activities. A lot of them mentioned that they didn't like socializing because it just came with so much having to think about, you know, would they be able to get in that area okay? How would they feel when they're there? If they needed to leave, would they be able to leave? And that also then impacted their abilities to carry out tasks on a daily basis. One thing that did come up that I didn't actually ask in my interview guide, but many participants commented on, was intimacy. So the idea that being intimate with their partners may provoke a vascular episode. That was something that a lot of them were very anxious and worried about. And lastly, achievements and accomplishments. So every single one of them felt that the condition had limited them in achieving certain milestones or goals in life, including things like work and study. So the next theme was risk perception and existential thoughts. So I think this whole theme was kind of centered around the uncertainty of living with vascular EDS, because each of these, that uncertainty sort of meant, well, it kind of determined a lot of things for them. So a lot of them lived cautiously because of that. They were very aware that the condition, of the impact of the condition. And for some of them, when they got their diagnosis, they were very fearful. Others were very relieved because they'd spent years and years trying to get a diagnosis and finally had something to say that was what it was, the cause of all the things they've been going through. One thing that came up was the idea of facing mortality. So they felt that they had to think about death a lot more than, say, the average person because of the uncertainty of the condition. And that then had an impact on how they viewed their future. So some participants would plan months and weeks in advance, whereas others would very much take each day as it came, just because they weren't necessarily sure that they would make it to the end of the week. Comparison came out quite a lot, especially with comparing life to what it would be like if they didn't have vascular EDS, and also comparing themselves to other people who are seemingly normal, and the idea that they are not normal. And even though the condition may not be visible on the outside, it's invisible because they are suffering on the inside. So communication and support, just throughout the whole entire process, it became very clear that communication was a vital component in their management of the condition, whether that was communication with family or friends. And every single participant mentioned that there was a lack of faith in healthcare professionals because of the lack of understanding and awareness. They felt that they weren't necessarily heard with healthcare professionals and weren't supported in the best way that they could be. And that also sort of led into when they would tell people about their diagnosis. Obviously, I recruited these participants through Annabelle's challenge, so all of them had experience of being in a support group. And interestingly, they all mentioned this idea of having a balance. So obviously the support group was amazing and it gave them companionship. They were able to walk alongside people who had similar journeys to them. But on the flip side, they were very aware that the more relationships they built, the more those relationships, sadly, you could lose those people to the condition. And they mentioned that you'd sort of have to go through that whole grieving process all over again. There was also a mention about relationships and how they felt that their condition had impacted their partners, so what they'd burdened them with. And lastly, differences within the community. So some people obviously were very positive on support groups, but others maybe had an element of competitiveness on whose symptoms were worse or who had the condition worse off. So that was communication and support. A world of responsibility came about because it just was very clear that each and every one of them carried a lot on their shoulders. For those that had children, whether those children were affected by vascular EDS or not, there was this huge weight of responsibility, and a lot of them were obviously guilty if their child did have the condition. And there was this constant sort of theme that came across that if they weren't there to protect their children, what would happen and how that would look. And that kind of also led into the personal health and management. So I mentioned about the lack of faith in healthcare professionals. Each and every one of them mentioned that they felt they had to own the condition. So they had to be knowledgeable about it because otherwise nobody else would be. It also affected their career progression, as I mentioned before, and financial uncertainty. So whether or not they should be saving for a pension or whether they should be spending that money now because they're not sure if they'll be able to live to claim that money. And lastly, raising awareness was very important for them. So that was another responsibility they felt they had. And the last two themes are loss and resilience and coping mechanisms. So every participant experienced some form of loss throughout their entire vascular EDS journey, and whether that was a loss of identity or a loss of freedom and independence due to the condition. For a lot of families or patients that didn't have children, it was the idea that they had to accept that they maybe wouldn't be able to have children. And also the impact of losing a family member to the condition was quite pertinent, because some of them use that family member as a basis as to whether how long they would live with the condition, for example. And the last theme, resilience and coping mechanisms, was one that I thought was really important, because it just showed how strong and resilient this group of people were. I thought they were really admirable in the way that despite all the things they had to face, they all still had a way of dealing with it and a way of remaining positive within their circumstances. So things like exercise, you know, even though some of them were very physically limited, they still tried to do low intensity exercise to help. This idea of just appreciating life and having a positive attitude was also really common. So yeah, it was amazing to hear how they deal with that on a daily basis. And just some of the sort of lasting additional findings I had, over half of the participants reported mental health issues due to the condition, and many of them accessed mental health support, the most common of which was CBT. And at the end of each interview, I asked every participant if there was anything they could think of that would help improve their experience of living with the condition, what would it be? And the most common answer, unsurprisingly, was increased awareness from healthcare professionals. And so I think what my research projects have shown is obviously that vascular EDS patients are faced with a huge ordeal of psychosocial issues, but additionally, by upskilling healthcare professionals to be able to sort of navigate and manage those psychosocial issues of the condition using either psychotherapeutic approaches or other ways of communication would be really useful for them, because it will help them feel like their voices are being heard and they are being supported. And lastly, I just thought I'd mention some of the future psychosocial research projects that I think would be really useful. On the side here, I've just put some of the quotes from participants, because every single one of them found the interview process empowering, and they all commented on this idea that they decided to sign up and do the research project so that they could raise awareness of the condition and actually contribute to the future care of vascular EDS patients. So I'll just quickly run through some of the other research projects I think would be useful. So obviously a larger sample size would be great, so you could hear more from different people and their experiences. The impact of age at diagnosis, I think, was so important, because there was a clear divide between those that had been diagnosed earlier in life and those that had been diagnosed later. Those diagnosed later were less restricted by the condition because they lived a lot of their lives without their diagnosis, whereas those that were diagnosed at a younger age were a lot more limited in what they had done because they've been diagnosed from such a young age. Male studies, I only had 3 male participants, so it would be good to hear their point of view in more detail as well. Intimacy and relationships, which I mentioned earlier, and quality of life studies, I also think would be useful. And then any studies that sort of look at other coping mechanisms or interventions that they could use to better their experience of living with the condition. So thank you very much for listening. I just want to thank Anabosh Challenge and the National EDS Service in Sheffield for all of their help and support throughout the entire thing. I am in the process of currently publishing my research, but I'm happy for you to email me any questions that you have and take any questions now. Thank you.
Okay, thank you again, Lynn.
Thank you so much.
Yes. Please just unlock your presentation. We have to move to the next and third presentation of Sarah Stephens on perinatal and neonatal outcomes among children with VEDS.
Thank you. I'll share my screen now. So for one, thank you all for your attention. I want to, for one, just thank once again, my co-authors and the DEFY Foundation for allowing us to present this. This talk is going to be talking about the perinatal and neonatal outcomes among children with VEDS. So no disclosures. So just to begin, there are larger cohort studies that identify that pregnant women with VEDS have higher risk of maternal complications in the standard population. We've seen this published by Dr. Byers' group. There's also some case reports describing adverse neonatal complications specifically, these including premature birth, congenital anomalies, and low birth weight. However, data describing the prevalence of these adverse neonatal outcomes that could potentially aid in counseling are rare. So the aim of this study was to examine the prevalence of perinatal and neonatal complications in a cohort of children with VEDS, primarily with a focus on the neonatal complications. We hypothesized, one, that the prevalence of preterm birth, birth weight, and congenital anomalies would be greater in this cohort of children with VEDS as compared to that of the general population. And then as a secondary hypothesis, we hypothesized that subjects with high-risk COL3A1 variants would demonstrate higher prevalence of preterm birth weight congenital anomalies as compared to those with low-risk variants. So for subjects, we recruited subjects from our local institution that were enrolled in a larger prospective study investigating the outcomes of patients with VEDS. Data was ascertained using both a self-reported history via subject interview, as well in conjunction with review of their medical records. We included subjects who had confirmed genetic diagnosis of VEDS via pathogenic COL3A1 variant or a deletion, as well as a clinical diagnosis. For our outcomes, we assessed gestational age to assess for preterm birth, as well as birth weight, both just as a crude measure, as well as a Z-score that was adjusted for the gestational age. We also looked at presence of congenital anomalies and the frequency of the most common ones. And lastly, we looked at documented complications in a small subset of mothers that gave birth that also had VEDS. So for comparisons, we compared outcomes in the cohort to the general population, and we compared this to, given we are in Texas and most patients are in Texas, the Texas population vital statistics data. Additionally, gestational age and birth weight were compared among those with and without an affected mother, and by risk stratified variant type. And we used Fisher's exact and Wilcox and rank sum tests to assess for that. So overall in the cohort, 30 subjects were included. These included, for one, everyone in the cohort was white, either being Hispanic white or non-Hispanic white. The majority of subjects, about 27 out of 30, had a high-risk variant that was either a splice site variant at 14 or a glycine substitution at 13. There were 7 subjects born with affected mothers, and nearly half of the cohort was born via C-section, with another, basically about half the cohort was born via vaginal delivery. So this figure indicates the distribution of gestational age among the entire cohort here on the left, as well as stratified by genotype classification here on the right. Of note, these lighter gray boxes in the middle indicate the normal range for all births in the general population. Here we can see the distribution of gestational age in the overall cohort, which had a median gestational age at 37 weeks. On the right is the distribution of gestational age, as I mentioned, when we stratified by either null or gene deletion in orange, the glycine in green, or the splice site in yellow. However, when we had assessed for differences in gestational age between high risk and low risk, where we combined these two and compared it to our low risk group here, we did not detect a statistically significant difference. And we can see this with a p-value of 0.14. And here, just one thing to note, the median gestational age among those with the high risk variant was 36 weeks, while those with the low risk variant were at 38. And here essentially is the same format, just looking at birth weight. We can see the overall birth weight in kilograms here at 2.9 for the overall cohort and an IQR of 2.3 to 3.4. And on the right are the distributions of birth weights by variant classification. Interestingly, when we had done the same, we had tested for differences in birth weight, looking at high versus low risk variants. We did find a statistically significant difference of 0.03. Among the subjects with high risk variants, the median birth weight was 2.98 kilograms as compared to 3.7 kilograms in the low risk cohort. And then lastly, here's a distribution of birth weight Z-scores. The overall median Z-score was 0.01, suggesting that birth weight was appropriate for gestational age. And when comparing Z-scores by birth weight, this difference was no longer statistically significant. So when we compared prevalence of preterm birth in our cohort to that of the general population, we found that preterm birth was significantly more prevalent in this cohort than that in the general population, with nearly half of our cohort being born before 37 weeks gestation. This figure here assesses the prevalence of the most common congenital anomalies in our cohort by genotype. Overall, 83% of subjects had at least one congenital anomaly at birth. Here I'm just documenting the top 3 that we saw. On the left here is pyloric stenosis, which we can see one is not present in anyone with a null variant or deletion, but was prevalent, but at lower proportions. And those with glycine substitutions and splice site variants. The 2 next most common ones were hindfoot valgus and flat feet, which we see present in all 3 groups and at higher proportions. And then lastly, looking at complications among affected mothers. So among the 4 affected mothers that had 7 deliveries, 3 of these had severe complications. These complications included 1 uterine rupture, 1 placental abruption, and 1 death due to reported cardiovascular collapse. Of note, all of these were in mothers with either a glycine substitution or a splice site variant. And lastly, when we assessed for the prevalence of preterm birth as a dichotomized outcome among subjects by their maternal affected status, there was no statistically significant difference. However, we can see visually that there is, maybe while not statistically different, a higher proportion of preterm birth among the affected mothers in our cohort as compared to those that are non-affected. And then of note, the median gestational age among affected mothers was 35 weeks, whereas the median gestational age for a woman who did not have VEDS was 37. So limitations of this study, again, just a small sample size due to the rarity of the condition and with that limited statistical power to detect significant differences. With that, there is a possible selection bias. As Dr. Morris had previously mentioned, we are a larger center. And with that, could be seeing children that have a more severe phenotype or have a more severe family history. And then with that, again, pointing back to the fact that there were no non-white subjects in our cohort. And so really pointing to the lack of racial diversity in this sample. So overall, we saw that preterm birth is significantly higher among neonates with VEDS as compared to the general population. Children with VEDS may be born with congenital anomalies. And our findings suggest that the abnormalities of fetal tissue and not maternal tissue are responsible for decreased gestational age at birth. However, further studies are needed to better understand the mechanisms of early outcomes in this population. And again, just want to say thank you to our co-authors, our funding sources, and all of you for your time. I'm open to questions at this time.
And we move to the third communication of this session, which is given by Rusinova Rubaltseva from Moscow, about a new rare genetic COL3A1 variant in a patient with a clinical phenotype of EDS.
Good afternoon, colleagues. My name is Victoria Rumyantseva. I am clinical geneticist from Petrovsky Russian Research Center of Surgery. I would like to share my experience. The Ehlers-Danlos syndrome in an umbrella term for a group of clinically and genetically heterogeneous connective tissue disorders. High mobility joints, easy bruising, and fragile skin are the well-known features of EDS. Classical EDS can be painful and disabling. It affected skin, wound healing, and joints. Vascular EDS is considered the most serious form of EDS due to the high risk of arterial or organ rupture and shortened lifespan. We have observed a Russian female patient, 26 years old, complaining of frequent hematomas either spontaneously or after a minor trauma. Several times she was treated with emergency surgical drainage. Routine blood coagulation tests were normal. She has typical classical EDS phenotype, smooth, velvet, hyperextensibility skin, multiple wading atrophic scarring, joint hypermobility, permanent joint dislocation, ipsocutaneous spheroids of the legs. The patient is planning a pregnancy and she is concerned if she has life-threatening risk. The patient underwent genetic testing via whole exome sequencing on Illumina platform, followed by capillary Sanger sequencing. Genetic testing relieved a rare heterozygosis transition of glutamine to lysine in the exon 19 of the COL3A1 gene in the proband's DNA. Her pedigree is compromised with sudden death due to the dissection aneurysm of the father's grandmother at the age of 50. And her father has aneurysm and hematomas now. Cascade family and screening revealed there is also this variant in the affected father. While we were preparing this report, the patient sent us a letter. Her father had complications during surgery. We cannot not use the criteria PM1 because we don't have a large family with 6 affected relatives. In connection with the available data, we interpreted this variant as an uncertain significance. By informatics tools, predict ambiguous effect on protein function, where PP3 criteria are directly opposite to BP4 criteria. A functional study of a new variant clarifies a clinical significance of this substitution. Sharing phenotypic data about carriers of glutamine 433 lysine variant may be add a new insights. As done in the guide for cardiomyopathies, multiple probands rule for MWH7 related phenotypes. We hope the genetics community could help us. Genotype-phenotype association studies will be necessary to future clarify the cause of the variability of the disease severity.